There's a pill sitting in your medicine cabinet right now that your doctor prescribed to help you, but it might actually be stealing your memory, increasing your fall risk, and shortening your life, and the most frightening part. Your doctor probably has no idea. I'm not talking about some rare medication that only a few people take. I'm talking about prescriptions that millions of seniors are given every single year. Pills that were studied on 40-year-olds but prescribed to 70-year-olds. Medications that were supposed to be taken for weeks but have been refilled for decades. In the next few minutes, I'm going to show you 5 specific medications that, after reviewing hundreds of medical studies and consulting with pharmacologists, gerontologists, and internists, I believe pose serious risks to adults over 60, risks that often outweigh their benefits. My name is Dr. and I've spent the last 18 years working in geriatric medicine. I've sat in hospital rooms with families asking the same question over and over. How did mom go from independent to confused in just a few months? And when I reviewed their medication list, the answer was right there. Not in a new diagnosis, not in some sudden decline, but in a prescription bottle that had been refilled automatically for 5 years. Before we go any further, I need to make something absolutely clear. Do not stop taking any medication without talking to your doctor first. Stopping certain medications abruptly can be dangerous, even life-threatening. What I'm giving you today is information, not instructions. Information you can bring to your doctor to have an informed conversation. The American Geriatric Society maintains something called the Beers Criteria. It's a list of medications that are potentially inappropriate for older adults. This list is updated every few years based on the latest research, and it contains dozens of commonly prescribed drugs. But here's the problem. Most primary care doctors don't specialize in geriatrics. They're incredibly skilled, they care deeply about their patients, but they're treating everyone from newborns to 95-year-olds. They simply don't have time to stay current on every medication interaction and age-specific risk. That's not a criticism, that's reality. A study published in JAMA Internal Medicine found that nearly 40% of adults over 65 are taking at least one medication listed in the Beers criteria. 40%. That's tens of millions of seniors. So today I'm going to walk through 5 of the most commonly prescribed medications that appear on that list, explain exactly why they're dangerous for older adults, what symptoms to watch for, and most importantly, what alternatives exist. If you're currently taking any of these medications, please don't panic. Instead, take notes, screenshot this video if you need to, and schedule a conversation with your doctor this week. And if you know someone over 60 who's taking multiple medications, share this video with them right now. You might be giving them information that could genuinely change their life. Let's get started. The first medication class that seniors must approach with extreme caution is Benzodiazepines. You might know them by brand names like Xanax, Ativan, Valium, or Klonopin. The generic names include alprazolam, lorazepam, diazepam, and clonazepam. These medications are prescribed for anxiety, insomnia, muscle spasms, and sometimes even for hiccups or nausea. They work by enhancing the effect of a neurotransmitter called GABA in your brain, which has a calming, sedating effect. And for short-term use in younger adults, they can be effective. The problem is, they were never designed for long-term use in anyone, and they're especially dangerous in older adults. Let me tell you about a patient I'll call Margaret. She was 68 when I first met her. Sharp, independent, lived alone, drove herself everywhere. She'd been taking Ativan for sleep for 7 years. Her original doctor retired, and her new doctor just kept refilling it. Over those 7 years, Margaret started falling. 3 falls. In 1 year, she became more forgetful. Her daughter noticed she seemed foggy during phone calls. Margaret herself felt like she was losing her edge. When I reviewed her medications and saw the Ativan, I knew immediately what was happening. We worked with her doctor to slowly, carefully taper her off the medication over 3 months. Within 6 months, Margaret's memory improved dramatically. The falls stopped. She told me, "I feel like myself again for the first time in years." So why are benzodiazepines so dangerous for seniors? Reason number 1, they increase fall risk dramatically. As we age, our balance naturally declines. Our reflexes slow down. Our bones become more fragile. Benzodiazepines sedate the central nervous system, which makes coordination, reaction time, and balance even worse. A comprehensive review in the British Medical Journal found that seniors taking benzodiazepines have a 50% increased risk of hip fracture compared to those not taking them, 50%. And a hip fracture after 65 isn't just a broken bone. It's often the beginning of a steep decline. 20% of seniors who fracture a hip die within 1 year. Many others lose their independence permanently. Reason number 2, they cause cognitive impairment that mimics dementia. Benzodiazepines affect memory formation, attention, and processing speed. In an older brain that's already experiencing some age-related changes, these effects can be devastating. I've seen patients diagnosed with early dementia who, after stopping benzodiazepines, showed remarkable cognitive improvement. The dementia wasn't Alzheimer's at all. It was medication-induced cognitive impairment. A study in the British Medical Journal in 2014 found that benzodiazepine use was associated with an increased risk of dementia, with longer use showing stronger association. Reason 3, they're incredibly difficult to stop. Benzodiazepines are physically addictive. Your brain becomes dependent on them, sometimes in as little as 2 weeks of daily use. Stopping them suddenly can cause severe withdrawal symptoms, including seizures, panic attacks, tremors, and extreme anxiety. This means that even when a doctor realizes the medication is causing harm, getting the patient off it safely requires a slow, careful taper that can take months. What you need to watch for if you're taking benzodiazepines: increased confusion or memory problems, dizziness or unsteadiness, daytime drowsiness, slurred speech, depression. Any falls or near falls. What are the alternatives? For anxiety, cognitive behavioral therapy has been shown in multiple studies to be as effective as medication, with longer-lasting results and zero side effects. There are also newer medications like XRIS that don't carry the same risks. For sleep, addressing sleep hygiene is the first step. That means consistent bed and wake times. Limiting screen time before bed, keeping the bedroom cool and dark, and avoiding caffeine after PM. There are also safer medication options for short-term sleep issues, like low-dose melatonin or trazodone, though even these should be used cautiously and temporarily. The key point is this: if you've been taking a benzodiazepine for more than a few weeks, especially if you're over 60, you need to have a conversation with your doctor about tapering off safely. Do not stop cold turkey. Work with your doctor to create a gradual reduction plan. It might take time, but your brain, your balance, and your independence will thank you. The second medication class is first-generation antihistamines. These are medications you probably recognize from the pharmacy shelf: Benadryl, which is diphenhydramine, Dramamine, Unisom, and many over-the-counter sleep aids contain the same active ingredient. There's also hydroxyne, often prescribed for anxiety or itching, and chlorpheniramine, found in many cold and allergy medications. Now you might be thinking, wait, I can buy Benadryl without a prescription. How dangerous could it be? This is one of the biggest misconceptions in medicine. Just because something is available over the counter doesn't mean it's safe, especially for older adults. First-generation antihistamines are called first-generation because they're the older versions. They work, but they cross into the brain easily, which causes sedation and a whole cascade of other problems. There are newer antihistamines, second-generation ones like Claritin, Zyrtec, and Allegra, that don't cross into the brain as easily and are much safer for seniors. Let me tell you about Robert, a 72-year-old man who came to see me because his wife was concerned about his memory. He was taking to Benadryl every night to help him sleep. He'd been doing this for over a decade. Robert's short-term memory was noticeably impaired. He was also having trouble with constipation, dry mouth, and occasional dizziness. I explained to him that Benadryl has what we call anticholinergic effects. Acetylcholine is a neurotransmitter crucial for memory and learning. When you block it, which is what these medications do, you impair cognitive function. We worked with his doctor to switch him to a safer sleep aid and address his sleep habits. Within 2 months, his wife reported that his memory had improved significantly. The constipation resolved. He felt sharper. So why are first-generation antihistamines problematic for seniors? Reason number 1. Strong anticholinergic effects. Anticholinergic medications block acetylcholine, which affects not just your brain but your entire body. In seniors, this can cause memory problems and confusion, blurred vision, dry mouth, constipation, urinary retention, increased heart rate. A landmark study published in JAMA Internal Medicine in 2015 found that seniors who took anticholinergic medications like diphenhydramine had a significantly increased risk of developing dementia. The risk increased with higher doses and longer duration of use. This wasn't a small study. Researchers followed over 3,400 participants for more than 7 years. Reason number 2, they cause excessive sedation and hangover effects. Unlike newer antihistamines, first-generation ones make you drowsy. In older adults, this drowsiness can last well into the next day, increasing fall risk and impairing driving ability. The American Geriatric Society explicitly recommends avoiding these medications in older adults for this exact reason. Reason number 3, they're in more products than you realize. This is the sneaky part. Diphenhydramine isn't just in Benadryl, it's in Tylenol PM, Advil PM, many store-brand sleep aids, cold and flu combination medications, even some topical creams. People often don't realize they're taking an anticholinergic medication because they're taking it for sleep or pain, not allergies. What should you watch for if you're taking these medications? Confusion or memory lapses, extreme drowsiness or difficulty waking up, dry mouth that doesn't go away, difficulty urinating, blurred vision, constipation. What are the safer alternatives? For allergies, switch to second-generation antihistamines like cetirizine, Zyrtec, loratadine, Claritin, or fexofenadine, Allegra. These don't cross the blood-brain barrier as easily and don't cause the same cognitive effects. For sleep, avoid using antihistamines altogether. Instead, talk to your doctor about melatonin and low doses cognitive behavioral therapy for insomnia, sleep hygiene improvements addressing underlying causes like sleep apnea or restless leg syndrome. For itching, there are prescription antihistamines that are safer, as well as topical treatments that don't affect your brain at all. The bottom line: if you're over 60 and you're regularly taking Benadryl or any product containing diphenhydramine, it's time to talk to your doctor about alternatives. The third medication class. that needs serious reconsideration is proton pump inhibitors, or PPIs. You know these by names like Prilosec, Nexium, Prevacid, and Protonix. The generic names are omeprazole, esomeprazole, lansoprazole, and pantoprazole. These are some of the most commonly prescribed medications in the world. They're used for heartburn, acid reflux, GERD, and to prevent stomach ulcers. They work by shutting down the pumps in your stomach that produce acid, and they work incredibly well. For someone with severe reflux or a bleeding ulcer, PPIs can be genuinely life-saving in the short term. But here's the critical issue. They were designed for short-term use, typically for 2 to 8 weeks. Yet I routinely see patients who have been on them for 5, 10, even 20 years. Let me share the story of Linda, a 66-year-old woman who came to me complaining of severe fatigue and weakness. She'd been taking Prilosec daily for 12 years for mild heartburn. Blood work revealed she had severe magnesium deficiency and vitamin B12 deficiency. She also had early signs of osteoporosis. I explained to Linda that long-term PPI use was likely the cause of all 3 problems. We worked with her doctor to gradually wean her off the medication while addressing her reflux with lifestyle changes. 6 months later, her energy was back, her magnesium and B12 levels normalized with supplementation, and her bone density scan showed slight improvement. So why are PPIs concerning for long-term use in seniors? Reason number 1, they interfere with nutrient absorption. Stomach acid isn't just there to digest food, it's essential for absorbing several critical nutrients. Vitamin B12, you need stomach acid to separate B12 from food proteins. Without it, you become deficient, which causes fatigue, nerve damage, memory problems, and depression. Magnesium. Long-term PPI use is associated with hypomagnesemia, low magnesium, which can cause muscle weakness, irregular heartbeat, and seizures. Calcium. Reduced stomach acid impairs calcium absorption, which is especially concerning for seniors already at risk for osteoporosis. Iron. Low acid makes it harder to absorb iron, potentially causing anemia. The FDA issued a warning in 2011 about the risk of low magnesium with PPI use, and multiple studies have confirmed increased fracture risk. Reason number 2, increased infection risk. Stomach acid is your first line of defense against bacteria and other pathogens you swallow. When you suppress that acid, you're essentially opening the door to infections. Studies have shown that PPI users have increased risk of pneumonia, higher risk of C. difficile infection, a dangerous intestinal infection, greater susceptibility to foodborne illnesses for a senior whose immune system is already less robust. This is a significant concern. Reason number 3, potential kidney damage. Multiple studies, including research published in JAMA Internal Medicine, have found an association between long-term PPI use and chronic kidney disease. While the exact mechanism isn't fully understood, the association is strong enough that if you have existing kidney problems, your doctor should be very cautious about prescribing PPIs. Reason number 4, possible increased dementia risk. Some studies have suggested a link between long-term PPI use and increased dementia risk, though this is still being researched. The theory is that PPIs may increase beta-amyloid deposits in the brain. While more research is needed, the potential connection is concerning enough to warrant caution. Reason number 5, rebound acid hypersecretion. Here's the cruel irony of PPIs. When you try to stop taking them, your stomach often produces even more acid than before you started. This is called rebound acid hypersecretion. This means people feel worse when they stop, so they go back on the medication, creating a cycle that's hard to break. What should you watch for if you're on long-term PPIs? Unusual fatigue or weakness, muscle cramps or tremors, frequent diarrhea, bone pain or fractures. Tingling or numbness in hands and feet. What are the alternatives? First, identify if you actually need the PPI. Many people start taking them for temporary heartburn and never stop. Ask your doctor, do I still need this? If you do need acid suppression, consider H2 blockers like famotidine Pepcid, which are less powerful but safer for long-term use. Lifestyle modifications, elevating the head of your bed, avoiding trigger foods, not eating within 3 hours of bedtime, losing weight if needed, antacids like calcium carbonate for occasional symptoms. If you've been on a PPI long-term, don't stop suddenly. Work with your doctor to taper slowly while implementing lifestyle changes to minimize rebound symptoms. Consider supplementing with B12 and magnesium while you're still on the medication, and get regular monitoring of these levels. The key message: PPIs are excellent medications for the right situation and the right duration. But if you've been on one for years without reassessing whether you still need it, it's time for that conversation. The fourth medication class that poses particular risks for seniors is a group of diabetes medications called sulfonylureas. These include glyburide, also called Glinase or Diabeta, glipizide glucotrol, and glimepiride Amaryl. Now I want to be very clear here. Diabetes is a serious condition that absolutely requires management. If your blood sugar isn't controlled, the consequences are severe: nerve damage, kidney failure, blindness, heart disease, amputations. So this is not about avoiding diabetes treatment. This is about choosing the safest, most effective treatment for older adults. Sulfonylureas work by forcing your pancreas to release more insulin, which lowers blood sugar. They've been around for decades and they're inexpensive, which is why they're still commonly prescribed. But for seniors, they come with significant risks that newer diabetes medications don't have. Let me tell you about George, a 71-year-old man with type 2 diabetes. He'd been taking glyburide for 8 years. His daughter called me one afternoon, panicked. She'd found George on the floor, confused and drenched in sweat. When paramedics arrived, his blood sugar was 38, dangerously low. This wasn't the first time. George had experienced several episodes of hypoglycemia over the past year, some requiring emergency intervention. We worked with his endocrinologist to switch him to metformin and a newer class of diabetes drugs. He hasn't had a single hypoglycemic episode since. So why are sulfonylureas particularly concerning for seniors? Reason number 1. High risk of hypoglycemia, dangerously low blood sugar. Sulfonylureas don't just help your body use insulin better. They force your pancreas to pump out insulin whether you need it or not. This means that if you skip a meal, exercise more than usual, or your kidney function declines, which happens naturally with age, you can experience severe low blood sugar. Symptoms of hypoglycemia include confusion and difficulty thinking, shakiness and sweating, rapid heartbeat, blurred vision, loss of consciousness, seizures. In an older adult, hypoglycemia can cause falls, car accidents, and even strokes or heart attacks. The brain needs a constant supply of glucose. When it drops too low, serious damage can occur. Research published in JAMA Internal Medicine found that nearly 100,000 emergency room visits each year among seniors are due to hypoglycemia from diabetes medications, with sulfonylureas being a leading cause. Reason number 2, weight gain. Sulfonylureas often cause weight gain, which seems counterproductive when treating a disease often associated with excess weight. The weight gain can worsen insulin resistance and make diabetes harder to control in the long run. Symptoms of hypoglycemia include confusion and difficulty thinking, shakiness and sweating, rapid heartbeat, blurred vision, loss of consciousness, seizures. In an older adult, hypoglycemia can cause falls, car accidents, and even strokes or heart attacks. The brain needs a constant supply of glucose. When it drops too low, serious damage can occur. Research published in JAMA Internal Medicine found that nearly 100,000 emergency room visits each year among seniors are due to hypoglycemia from diabetes medications, with sulfonylureas being a leading cause. Reason number 2, weight gain. Sulfonylureas often cause weight gain, which seems counterproductive when treating a disease often associated with excess weight. The weight gain can worsen insulin resistance and make diabetes harder to control in the long run. Reason number 3, declining kidney function. As we age, kidney function naturally declines. Many sulfonylureas, especially glyburide, are processed through the kidneys. When kidney function drops, these medications can accumulate in the body, dramatically increasing hypoglycemia risk. Yet I've seen patients with reduced kidney function still taking glyburide because nobody reassessed their medication regimen. Reason number 4, they may not protect the heart. Newer diabetes medications like SGLT2 inhibitors and GLP-1 agonists have been shown in major studies to reduce the risk of heart attack, stroke, and cardiovascular death in people with diabetes. Sulfonylureas don't offer these protective benefits. In fact, some research has raised questions about whether they might actually increase cardiovascular risk. What should you watch for if you're taking sulfonylureas? Episodes of shakiness, sweating, or confusion, especially before meals, unexplained weight gain, frequent low blood sugar readings on your glucose meter, increased hunger. What are the safer alternatives? There are several diabetes medications that are safer for seniors. Metformin is still the first-line treatment for type 2 diabetes in most cases. It doesn't cause hypoglycemia when used alone, and it's been proven safe and effective for decades. DPP for inhibitors like sitagliptin and Januvia work with your body's natural insulin response and have very low hypoglycemia risk. GLP-1 agonists like semaglutide, Ozempic, or dulaglutide, Trulicity not only control blood sugar but also help with weight loss and protect the heart. SGLT2 inhibitors like empagliflozin and Jardiance also protect the heart and kidneys and don't cause hypoglycemia on their own. The American Geriatric Society specifically recommends avoiding glyburide in older adults due to the high risk of severe, prolonged hypoglycemia. If you're currently taking a sulfonylurea, especially glyburide, schedule an appointment with your doctor to discuss whether a safer alternative might be appropriate. Bring your blood sugar logs. Be honest about any episodes of low blood sugar, even minor ones. Ask specifically, are there newer medications that might be safer for me? And if cost is a concern, which is a very real issue, be upfront about that too. Some newer medications have patient assistance programs, and your doctor may be able to find solutions you weren't aware of. Managing diabetes is critical, but managing it with the safest medication for your age and situation is even better. The fifth medication class that seniors should approach with extreme caution is muscle relaxants. These include medications like cyclobenzaprine, Flexeril, carisoprodol, Soma, methocarbamol, Robaxin, and orphanadrin. These are commonly prescribed for back pain, neck pain, muscle spasms, and injuries, and in younger adults. For short-term use after an injury, they can be helpful, but in older adults, muscle relaxants are on the beer's criteria as potentially inappropriate medications, and for good reason. Let me tell you about Dorothy, a 69-year-old woman who threw out her back while gardening. Her doctor prescribed Flexeril to help with the muscle spasms. 3 days later, Dorothy fell getting out of bed in the middle of the night. She broke her wrist and suffered a concussion. When I reviewed her case, it was clear that the sedation and dizziness from the muscle relaxant had caused the fall, and the fall had caused far more harm than the original back pain ever would have. So why are muscle relaxants so problematic for seniors? Reason number 1, they cause significant sedation and cognitive impairment. Most muscle relaxants work on the central nervous system, causing drowsiness, dizziness, and confusion. In an older brain, these effects are often magnified. Cyclobenzaprine, one of the most commonly prescribed, is structurally similar to older antidepressants and has strong anticholinergic effects. Remember, those are the same effects we talked about with antihistamines: memory problems, confusion, blurred vision, constipation. Reason number 2, dramatically increased fall risk. Multiple studies have shown that muscle relaxants significantly increase the risk of falls in older adults, and we know that falls are one of the leading causes of injury, disability, and death in seniors. A fall that might result in a bruise for a 30-year-old can mean a hip fracture, hospitalization, surgery, and loss of independence. For a 70-year-old, reason number 3, limited evidence of effectiveness. Here's something most people don't know. The evidence that muscle relaxants are actually effective for back pain is weak, even in younger adults. A Cochrane review of muscle relaxants found that while they may provide short-term relief of symptoms, the effect is modest and the risk of side effects is high. In other words, they might help a little, but the risks often outweigh the benefits, especially in seniors. Reason number 4, no benefit over safer alternatives. For muscle pain and spasms, there are safer approaches that are often just as effective. Physical therapy, heat and ice, gentle stretching, over-the-counter pain relievers like acetaminophen or ibuprofen, used cautiously, topical treatments like lidocaine patches. These approaches don't carry the risk of falls, confusion, or dangerous drug interactions. What should you watch for if you're taking muscle relaxants? Excessive drowsiness, especially during the day, dizziness when standing or walking, confusion or difficulty concentrating, dry mouth and constipation, difficulty urinating. What are the alternatives? First, address the underlying cause of the muscle pain. Is it from poor posture, weak core muscles, arthritis, a specific injury? Non-medication approaches. Physical therapy. A physical therapist can teach you exercises to strengthen supporting muscles and improve flexibility. Heat and ice. Heat can relax tight muscles, while ice reduces inflammation. Gentle movement. Complete rest often makes back pain worse. Gentle walking and stretching can be more helpful. Topical treatments. Lidocaine patches or topical NSAIDs can provide localized relief without systemic side effects. Safer medications if needed. Acetaminophen, Tylenol for pain relief, used at the lowest effective dose. Short-term use of NSAIDs like ibuprofen if you don't have kidney problems or stomach issues. Topical NSAIDs like diclofenac gel, which has minimal systemic absorption. The American Geriatric Society specifically recommends avoiding muscle relaxants in older adults due to the anticholinergic effects and sedation. If your doctor prescribes a muscle relaxant, ask, are there alternatives we could try first? I'm concerned about fall risk and side effects. If you're currently taking a muscle relaxant regularly, it's time to reassess. These medications were designed for short-term use, typically no more than 2 to 3 weeks. Work with your doctor to address the underlying cause of your pain rather than masking it with a medication that carries significant risks. Now, if you're watching this and you recognize one or more of these medications in your own medicine cabinet, I want you to take a breath. Do not panic. And please, do not stop taking any medication without talking to your doctor first. Stopping certain medications suddenly can be dangerous. Benzodiazepines can cause seizures if stopped abruptly. Stopping PPIs can cause severe rebound heartburn. Stopping diabetes medications without a replacement can lead to dangerously high blood sugar. What I want you to do instead is this. Step 1. Make a complete list of every medication you're taking. Include prescription medications, over-the-counter drugs, vitamins, and supplements. Write down the name of each medication, the dose you're taking, how often you take it, what it was originally prescribed for, how long you've been taking it. This list is essential. Many seniors are taking medications prescribed by different doctors who don't communicate with each other. Your primary care doctor might not know what your cardiologist prescribed, and vice versa. Step 2. Schedule a medication review with your doctor. This doesn't have to be a separate appointment. You can do this at your next regular visit, but specifically ask for a medication review. Say something like, I'd like to go through my medication list and make sure everything is still necessary and appropriate for my age. Be prepared to ask specific questions. Do I still need this medication? Is there a safer alternative for someone my age? What would happen if I stopped taking this? Are any of my medications interacting with each other? Step 3. Bring information with you. If you've experienced symptoms that might be medication-related, write them down. Falls, memory problems, dizziness, constipation, whatever you've noticed. Doctors can't address problems they don't know about. Don't assume they'll ask about every possible side effect. Step 4. Consider seeing a geriatric specialist or a clinical pharmacist. Geriatricians specialize in the care of older adults and are specifically trained in age-appropriate prescribing. Clinical pharmacists, especially those who specialize in geriatrics, can do comprehensive medication reviews and work with your doctor to optimize your regimen. Many hospitals and clinics now offer medication therapy management services, sometimes covered by Medicare. Step 5. Be your own advocate. You have the right to question your medications. You have the right to ask about alternatives. You have the right to say, "This medication is making me feel worse, not better." Good doctors welcome these conversations. They want you to be an informed, engaged participant in your care. If your doctor dismisses your concerns without discussion, it might be time to find a doctor who listens. Step 6. Implement the changes safely. If you and your doctor decide to stop or change a medication, follow the tapering schedule exactly. Don't rush the process. Some medications require very gradual tapering over weeks or even months. It might be frustrating, but it's essential for your safety. Step 7. Monitor for changes. When you stop or change a medication, pay attention to how you feel. Keep a simple journal. How's your energy? How's your memory? Have you fallen or felt dizzy? How's your mood? This information helps your doctor understand if the change is helping or if adjustments are needed. Now I want to address something that goes beyond these 5 specific medications. It's the larger issue of polypharmacy, the term we use when someone is taking multiple medications simultaneously. There's no exact number that defines polypharmacy, but many experts use 5 or more medications as the threshold. And here's the sobering reality. According to research published in the Journal of the American Geriatric Society, nearly 40% of adults over 65 are taking 5 or more prescription medications. About 20% are taking 10 or more. Each medication comes with potential side effects, but when you combine multiple medications, the risks multiply exponentially. Drug interactions aren't just about 2 drugs that shouldn't be taken together. They're about how 5, 6, 7 medications all interact with each other and with your aging body. Let me paint a picture. For you. You're 68. You have high blood pressure, so you take 2 medications for that. You have high cholesterol, so you take a statin. You have diabetes, so you take 2 medications for that. You have arthritis pain, so you take a daily NSAID. You have trouble sleeping, so you take an over-the-counter sleep aid. That's 7 medications. Right there, and this is a very common scenario. Now, one of your blood pressure medications makes you dizzy, so you move more slowly and carefully. The NSAID irritates your stomach, so you start taking a PPI. The sleep aid makes you drowsy during the day, so you drink more coffee, which raises your blood pressure. The PPI reduces your magnesium absorption, which makes your muscles cramp, so you take a muscle relaxant. See how this snowballs? We end up treating the side effects of medications with more medications. It's called a prescribing cascade, and it's incredibly common. A study in JAMA Internal Medicine found that prescribing cascades occur in nearly 30% of older adults starting certain medications. Here's what often happens. Side effect mistaken for new medical problem. New medication prescribed to treat the side effect. New medication causes additional side effects. Cycle continues. The solution isn't to avoid all medications. Many medications are absolutely essential and life-saving. The solution is regular, thoughtful review. Questions to ask regularly. What would happen if I stopped this medication? Is this medication treating a symptom that might be caused by another medication? Is there one medication that could replace 2 I'm currently taking? Am I taking the lowest effective dose? Is there a non-medication approach I could try? There's a concept in geriatric medicine called deprescribing. It's the process of carefully reducing or stopping medications that may no longer be beneficial or that may be causing harm. Research has shown that deprescribing, when done carefully and appropriately, can reduce fall risk, improve cognitive function, reduce overall medication side effects, maintain or even improve quality of life, save money. A landmark study in JAMA found that when doctors systematically reviewed and reduced potentially inappropriate medications in older adults, adverse drug events decreased by 30%, just by stopping or changing inappropriate medications. I know some of you watching this might be thinking, my doctor is going to think I'm questioning their expertise or I don't want to be difficult. Let me reframe this for you. Bringing information to your doctor and asking questions isn't being difficult. It's being responsible for your own health. Good doctors appreciate patients who are informed and engaged. They don't want you suffering from preventable side effects any more than you do. Here's how to approach this conversation. Start collaborative, not confrontational. Instead of, I read that this medication is dangerous and I want to stop it, try, I've been reading about medications for older adults, and I'm wondering if we could review my list to make sure everything is still appropriate for me. Be specific about your concerns. Instead of, I think this medication is making me feel bad, try, since I started this medication, I've noticed increased dizziness and I've had 2 near falls. Could this be related? Ask open-ended questions. What are the alternatives to this medication? How do we know this is still helping me? What are the risks if I continue versus if I stop? Bring evidence, not just opinions. If you've done research, mention the source. I saw that the American Geriatric Society recommends avoiding this medication in older adults. Can you help me understand if there's a reason I'm an exception? Acknowledge the complexity. I know there are a lot of factors to consider. I'm not suggesting we change everything at once. I'd just like to make sure we're regularly evaluating what I'm taking. Express your goals. My main goal is to maintain my independence and mental clarity. I want to make sure my medications support that goal rather than working against it. If your doctor is resistant, some doctors, unfortunately, don't respond well to patient questions. If your doctor becomes defensive, dismissive, or refuses to discuss your concerns, you have options. Ask for a referral to a geriatric specialist for a medication review. Seek a second opinion. Consider finding a new primary care doctor who values collaborative decision-making. You deserve a doctor who listens to you and treats you as a partner in your care, not just a passive recipient of prescriptions. Now let's talk about prevention. How do you avoid getting on inappropriate medications in the first place? Strategy 1. Always ask before starting a new medication. When a doctor suggests a new prescription, ask, what is this for? How long will I need to take it? What are the common side effects, especially for someone my age? Are there alternatives we could try first? What happens if I don't take this? Strategy 2. Start low and go slow. This is a principle in geriatric medicine. Older adults are more sensitive to medications, so starting with the lowest possible dose and increasing gradually is safer. If your doctor prescribes a medication, ask, could we start with a lower dose to see how I tolerate it? Strategy 3. Keep an updated medication list with you at all times. Keep a card in your wallet or a note on your phone with all current medications and doses, all allergies, your pharmacy contact information. This is crucial if you end up in an emergency room or see a specialist who doesn't have access to your full medical record. Strategy 4. Use one pharmacy for all your prescriptions. Pharmacies have sophisticated systems that check for drug interactions, but they can only check what they know about. If you fill prescriptions at 3 different pharmacies, none of them have the complete picture. Using one pharmacy creates an additional safety net. Strategy 5. Get a comprehensive medication review annually. Even if you're feeling fine, ask for an annual medication review. This should be a standard part of preventive care for anyone over 60. Strategy 6. Be cautious about accepting free samples. Doctors sometimes offer samples of newer, brand-name medications. While this seems helpful, these newer drugs are often more expensive and you might not need the latest and greatest. Ask, is there a generic alternative that would work just as well? Strategy 7. Don't assume that because you've taken something for years, it's still appropriate. Your body changes as you age. Your kidney function, liver function, metabolism, and sensitivity to medications all change. A medication that was perfectly safe at 55 might be risky at 75. Let me share one more story that ties this all together. I had a patient named Eleanor who was 73 when she first came to see me. She'd been living independently, driving, managing her own finances, volunteering at her church. Over the course of about 18 months, her family watched her decline. She became forgetful. She stopped driving after 2 minor accidents. She fell 3 times. She seemed depressed and withdrawn. Her daughter was convinced it was Alzheimer's and was researching memory care facilities. When I met Eleanor, she was taking 14 different medications. 14. Among them, a benzodiazepine for anxiety she'd been on for 8 years, Benadryl nightly for sleep, a PPI she'd been on for over a decade, a muscle relaxant for chronic back pain, 2 blood pressure medications that were causing dizziness. After reviewing her medications and her symptoms, I sat down with Eleanor, her daughter, and her primary care doctor. Over the next 6 months, we carefully, systematically reduced her medication list. We tapered off the benzodiazepine. We stopped the Benadryl and addressed her sleep with better sleep hygiene. We discontinued the PPI after addressing reflux with diet changes. We stopped the muscle relaxant and started physical therapy. We adjusted her blood pressure medications to stop the dizziness. The transformation was remarkable. Within 3 months, Eleanor's memory noticeably improved. The falls stopped. Her mood brightened. She started driving again. Within 6 months, she was back to volunteering, back to her book club, back to being herself. Her daughter cried in my office. She said, "We thought we were losing her. We thought it was dementia. It was the medications all along." Eleanor isn't unique. I've seen versions of this story dozens of times. Not every case is this dramatic, and I want to be clear that medications aren't always the culprit. Sometimes cognitive decline is truly Alzheimer's or another form of dementia, but medication-induced cognitive impairment is vastly underdiagnosed and undertreated. And the tragedy is that it's reversible if caught in time. So let me bring this all together. We've talked about 5 medication classes that pose significant risks to older adults. Benzodiazepines increasing fall risk, cognitive impairment, and dependency. First-generation antihistamines causing sedation, confusion, and dementia risk. Proton pump inhibitors when used long-term, interfering with nutrient absorption and increasing infection risk. Sulfonylureas causing dangerous low blood sugar episodes. Muscle relaxants dramatically increasing fall risk with limited benefit. If you're taking any of these, you now have the information you need to have an informed conversation with your doctor. But beyond these specific medications, the bigger message is this: you are not powerless when it comes to your medications. You have the right to understand what you're taking and why. You have the right to ask questions. You have the right to request alternatives. Your body is changing as you age, and your medications should change with it. What worked at 50 might not be appropriate at 70. What was prescribed 10 years ago might no longer be necessary. Regular medication reviews aren't just a good idea, they should be a standard part of your healthcare. And if your current doctor isn't open to having these conversations, it might be time to find one who is. I want you to do something for me right now. If you found this information valuable, if you learned something that might help you or someone you love, do 2 things. First, like this video. It helps YouTube show this to more people who need it. Second, share it. Send it to a family member, a friend, a neighbor. Post it on Facebook. Email it to your book club. You might genuinely save someone from a preventable medication complication. And if you want more content like this, real research-based health information specifically for adults over 60, subscribe to this channel. Topics like how to prevent falls, how to protect your memory, how to navigate Medicare, how to maintain independence as you age. This is information your doctor might not have time to discuss in a 15-minute appointment, but it's information you deserve to have. Before we end, I want to say one more thing. Getting older comes with challenges. There's no getting around that. But so many of those challenges are made worse by medications that weren't designed for older bodies or weren't meant to be taken indefinitely. By being informed, by asking questions, by advocating for yourself, you can avoid so much unnecessary suffering. You've worked too hard and lived too long to have your independence, your mental clarity, or your quality of life stolen by an inappropriate medication. Take action today. Pull out your medication list. Make an appointment with your doctor. Ask the questions. Your future self will thank you. I'm Dr. Thank you for watching. Thank you for trusting me with your time, and I'll see you in the next video. Stay healthy, stay informed, and take control of your care.